Welcome to Awakening the Body, conversations around sexuality, psychedelics, trauma, shame, acceptance, and loving self-kindness. How can we bravely co-create safe enough spaces for our erotic and ecstatic selves to emerge and flourish, opening up to radical self-love for our weird, wonderful, and full beingness? I'm your host, Rachel Charlie, somatic sex educator, living in George, Montreal, on the unceded Indigenous lands of the Koniengohaki Mohawk Nation. This 10th episode is a conversation with Jaclyn Lanthier around Lichen Sclerosus. We talk about what it is, the importance of diagnosis, hormones and their possible importance as an adjunct therapy, self-touch and myofascial release, vibrators, and how much care and love is necessary for all of us, for all of our genitals. Jaclyn is a vulvar lichen sclerosis patient advocate from Toronto, Canada. Jaclyn is the founder and director of the Lost Labia Chronicles, an evidence-based knowledge-sharing hub for vulvar lichen sclerosis information and support. She's on the executive board of Lichen Sclerosus Network, a non-profit organization based in the USA. She's currently enrolled in the EUPATI, EUPATI, patient expert training program to improve her skills in patient advocacy. Jaclyn did her Ph.D. in philosophy of neuroscience at the Western University in London, Ontario, where she evaluated the scientific methods and protocols used in cognitive neuroscience research to assess the reliability of the findings and ensure that the conclusions drawn from these studies are credible and trustworthy. Jaclyn is passionate about science communication, knowledge translation, and improving the quality of life of people with vulvar lichen sclerosis through education and support. You can find her website at www.lostlabia.com, on Instagram at the Lost Labia Chronicles, and also on Facebook at the Lost Labia Chronicles. These links are in the show notes, as well as many more. If you are interested in financially supporting this podcast, you can find a link to buy me a coffee in the show notes. Thank you, and thank you for listening. I hope that you enjoy this show as much as I did. Yay. Hey, Jaclyn. Thanks for coming onto the podcast. It's so great to have you here.
Thank you so much. I've been really excited to have this conversation with you.
Yeah, I've been following you for a little while on the Lost Labia Chronicles and Lichen Sclerosus Support Network and learning about what is lichen sclerosis, what support do we have, anything else as well, right? So it's such a pleasure to have you here and talk to you and just talk about what is lichen sclerosis and hopefully have it reach a few people to spread the word about what it is, how prevalent and underdiagnosed it really might be, so that all the people that need support and help, including partners and friends of folks that have it and family, can all pull together.
Yeah, 100%.
Yeah. So this is for you. What is lichen sclerosis?
Yes, that's always the big question, right? And when I got my diagnosis, when I finally, after over 10 years, got my diagnosis, and my GP within seconds of looking at my vulva said, "Jaclyn, you have lichen sclerosis." And I said, "What is that?" Because most of us have probably never heard of this term before. And for those of you who already have a diagnosis, often that's our first encounter with that term, lichen sclerosis, is when we actually get the diagnosis, because it's just not typically something that's talked about a lot. So it's really throws a lot of people off guard. But essentially what lichen sclerosis is it is a chronic, highly inflammatory, progressive skin condition. It can affect the extragenital skin, technically speaking anywhere, but common areas are like the breast, the arms, the belly, the thighs. Those are kind of common areas for extragenital, so non-genital parts of the body. although lichen sclerosus does seem to have a kind of preference, and more commonly it affects the genitals. Now, that can be penises or vulvas, and Rachel and I are going to get more into that in a bit. A lot of my work personally centers around vulvar lichen sclerosis. Same thing for Lichen Sclerosus Support Network. Again, we're going to have a great conversation about why that is. But just know, skin condition, chronic, inflammatory. There's a lot of research that came out in the last 5 years or so from the realm of genomics showing that it is an autoimmune reaction at the local skin level. So it's not the same as having a systemic autoimmune condition where it's kind of affecting all of our organs. The autoimmune reaction is really just happening at the local tissue level. So for the vulva, it's, happening in that vulvar tissue, but it's not really affecting any other areas of the body. That in terms of signs and symptoms can vary, of course. Itch is a big one. And how itch presents is going to differ from person to person. Some people don't even have an itch component. If you have an itch component, it could be random and mild and sporadic. So it just kind of seems to come out of the blue with no rhyme or reason. For others, that itch is a lot more persistent, more chronic, more debilitating and intense. And then there's everywhere in between in that spectrum. Then there's kind of like the pain category, and how people present with pain or report pain sensations is going to vary. So some common adjectives are like soreness, rawness, burning, tenderness, aching. These are the types of words that people will often use to describe their pain. And then, of course, you have like the sexual health related symptoms. This could be, and I'm talking all for the most part about vulvar lichen sclerosis. So pain with insertion, tearing with insertion. Common areas would be the opening of the vagina and the fourchette area, although tearing can happen anywhere on the vulva. And pain with sex, those are kind of common sexual health symptoms, as well as decreased or loss of clitoral sensation. So those are kind of like, the main buckets of lichen sclerosis and how it presents. And it's just really important to note here that you don't need to have every single sign or every single symptom to have the diagnosis. Some people get a diagnosis and start to wonder if they were misdiagnosed because they see online, all these people have itch and I don't have itch. That doesn't mean it's not LS. There's a lot of people that just have a pain component or just have a sexual health component, just an itch. And there are people that are even asymptomatic. Those people don't have symptoms, but what they do have is physical signs of lichen sclerosis. So signs are things that we can see. So I can't see itch on your body. If you have a rash, I might be able to infer that your arm might be itchy based on the look of the rash, but I don't physically see itch on your body. So with signs, we do. So for signs of vulvar lichen sclerosis, again, these can vary, but the texture of the skin will change. So it could present as really, really thick, hard skin, sometimes in patches in different areas. For some people, it's the opposite. It looks more thinned out, more like parchment paper. It can be like glossy and wrinkly. So textural changes are one of the things that clinicians are trained to look for. The other thing they're trained to look for is color changes. So lichen sclerosis causes us to lose pigmentation. That's often a big classic lichen sclerosis sign. How that presents is going to depend on your skin type. So folks of darker skin types, that's going to actually look a little bit more pronounced. Sometimes, commonly for folks with darker skin types, they get misdiagnosed as vitiligo because the contrast between their skin and that loss of pigmentation is so sharp that people assume vitiligo and make that assumption. People of lighter skin types, it's not always such a stark contrast, especially if you're quite pale to begin with. So just noting that loss of pigmentation can present differently on different skin types is an important one for patients and providers, quite frankly. And then there's changes to the physical appearance of how the vulva looks. So these are things like fusing, where two parts might stick together. So they're kind of stuck. So for folks that are kind of watching the video, you see I've put my two hands together. These are two separate hands. But now I've fused them together, but you can still see that they're two separate hands, but they're stuck. If someone tried to pull them apart, it would be a challenge. Now, what can sometimes happen too is that two parts can almost resorb. So one kind of melts into and resorbs into the other, such that now you don't see two hands anymore. You only see one. If I closed my eyes and tried to identify where the labia majora, the outer lips, and the labia minora, the inner lips are, if I ran my hand across there, I would only feel one thing. I would no longer feel two separate parts because the labia minora is basically resorbed into the surrounding tissue, which is the labia majora. That is what happened to me. Hence me calling, my whole platform, the Lost Labia Chronicles, was actually a way to kind of reclaim and heal from a lot of the pain that I experienced from losing that part of my anatomy. Another big change that can happen is that the clitoral hood can partially or completely fuse over the clitoris, the glans clitoris, such that if you try to retract, i.e. pull that hood up, you may only be able to see part of the glans, or in my case, if you have full phimosis, you may not be able to visualize the glans at all. And that can lead to decreased sensation. It can also lead to keratin pearls, which can be painful and can, in some cases go to infection. So there's a lot going on there. And then there's like other things that can happen, like blood blisters and bruises and stuff like that as well.
So the phimosis, I think of phimosis as like, I think of a lot our genitalia, like penises, vulvas, being pretty similar. So with folks with penises, that haven't been circumcised, it'll often mean like a fusing of the foreskin over the top.
Exactly.
Yeah.
Mm-hmm. Yeah. And that's quite common for people with penises who have lichen sclerosis. And again, there's this huge kind of myth that, it only happens to people with vulvas, and that is definitely not the case at all.
And there's another myth that it only happens to uncircumcised penises as well.
Right.
Because one of the other parts that lichen sclerosis is often seen on is around the anus.
Yes,
and that's
correct.
also, and because of what happens with the perineum on all genders, but particularly if you have a vagina, the perineum becomes so scarred and fused that it's like the skin tries to cover the entrance to the vagina. And then that can often be painful for
folks
like putting anything inside the vagina, just taking care of that area, because it can tear very easily as well.
Absolutely, yeah, because the entrance of the vagina, I'm making it a little bit dramatic just for the sake of like visualization, but pretend that's the opening of your vagina. So what Rachel was saying, the scar tissue can slowly build up. And so you might have what appears, if you've seen pictures online, it looks like a literal shelf of scar tissue. But now you might see that vaginal opening is now at half capacity. So it kind of narrows that opening. You would imagine if the vagina, the vaginal opening is narrow, that insertion now becomes challenging, painful, and can lead to more tearing, which then leads to more scarring. It becomes this vicious cycle that's really challenging to navigate.
Yeah. So all those, that's a lot, isn't it? That's a lot for anyone that doesn't know what this is.
Right. Yes. And that doesn't even touch diagnosis or gold standard treatment and adjunct therapy and all of that. That's really just like a high level. Here's what it is. Here's how it can present.
And because like I work with genitals, I get to see a lot of them. And because they all look so different, it's really hard to see it on people, because what could be in a labial resorption might just be smaller internal labia. So it's it takes a really good eye of a doctor to see. Often doctors aren't trained in it, or to know that it exists, but to see it. Yeah,
I agree. I think that poses a huge challenge in many ways. So one way that poses a challenge is that many people don't see the same doctor every single time or over a long-term period. So one thing, I had mentioned that my diagnosis took over 10 years, and I probably saw over 20 different doctors because I was moving a lot. I was in grad school. So if each person is seeing my vulva for the first time, to your point, they may just think, oh, she has smaller labia. That's normal. Her skin's a little paler, but she's pale too. That must be her baseline color. You can make these assumptions because vulvar diversity, genital diversity is so vast, right? And so, and then the other challenge that people get is they get an LS diagnosis, they come back to their doctor, 12 months follow-up, and they say, I've lost more of my labia. And the doctor says, no, you haven't. It's fine. You didn't lose it at all. And that's incredibly frustrating. Obviously to the person who's living with it. And so one thing that I always say is, take pictures if you feel comfortable. because that's an objective thing that you can point to and say, yeah, but this is what I looked like 12 months ago. And here's what we're working with now. Because the truth is, unless they're taking photographs, and most clinics don't have permission to take photographs of genitals, unless they're taking photographs and comparing, they do not remember what you looked like 12 months ago. I'm sorry. The amount of genitals that they are going to see in 12 months, please, they do not have a precise, like exact remembering of exactly how your labia looked like. So again, it's a challenge because that could look normal. But if I had full labia back then and now I don't, something's happening and I need your support in that. So there's a lot of challenges that, I think patients and providers have to work with when we think about how diverse genitals can appear, because they really are.
Yeah. So one question that I've had for a long time, I don't know if you want to go here yet. We've got a few places to go. So if you have another preference, we'll do that. But so I see a lot of different genitals in my work, and I see what looks to be lichen sclerosus equally on all the kinds of genitals, right? And so talking to you, we had a conversation. It's like you have some people with penises that come, but there's not much discussion around men around this. So what are the barriers to men getting a diagnosis? What are the barriers for men talking about it when a lot of folks with vulvas are starting now to talk about it?
I think there's so many barriers to people with penises getting an appropriate diagnosis. One is awareness on the provider side, and this is still something that exists in the vulvar space, but is really, really changing. There's a lot of continuing education and stuff going on in the vulvar health space to catch clinicians up. And I'm talking about even just like GPs, so family doctors, getting them up to speed. That awareness is really not there when it comes to penile lichen sclerosis. So I think one challenge is, even if doctors are examining the penis, they may not even think about a lichen sclerosus diagnosis. And phimosis can be caused by many things. So if a person with a penis presents with, penile phimosis, and they don't know what lichen sclerosus is, they may just treat the phimosis without even thinking of doing a further exam, a further check, a potential biopsy, asking certain questions, relating to sex and urination and all of these things. So I think one thing is a lack of awareness on the provider side. I think another thing is, stigma and shame. Getting people with penises to even go into a doctor in the first place is a challenge, because there's so much like social cultural things built into that. We don't see doctors, like, I'm tough, I just have to tough through this. There's so many narratives, I think, that persist that kind of might block an individual from even going in to see a healthcare provider in the first place. And then even if they're willing, what I hear often is like, well, where do I even go? Because, people with vaginas, most of us have been going to see a gynecologist for ages, if nothing else for periods. But people with penises don't kind of like really see anybody unless there's a major issue. And oftentimes, even then, it's more likely to be an STI clinic for, screening or something like that. And for anyone wondering, the most appropriate doctor for this would probably be a urologist. But a lot of people don't know that. A lot of people don't even know what a urologist is, that they exist. They wouldn't even know to kind of advocate with their family doctor, like, hey, something's going on with my penis. Can you do an exam? And if they don't know, can you give me a referral to a urologist? So I think, that's another thing, not knowing who to see, as well as this kind of shame and stigma and resistance to and hesitancy to even step into a healthcare provider's office.
And I can also add with men, so I've seen what might be lichen sclerosus in quite a few of my clients. And so far, every person with a vulva that I've said, hey, do you want to get this checked out, has gone to get it checked out.
Right.
And all the people with penises that I've suggested, and there have been quite a lot, not one of them has. been to a doctor.
Right.
And it's challenging because with the work I do, I need to make sure that they're getting, if they need medical support or help or a diagnosis, they need to get that before they can work with me, because if there's lichen sclerosis there, I need to know, they need to know, and they need support.
Yeah.
Because
in
it's
both
likely,
ways.
because it's in both ways, but it's likely that the things that they're coming to me for are directly related to that, if that's the case. And if it's not the case, then what is going on, right? So
right. Well, and that's it too. That would be, kind of my follow-up question. Maybe it isn't lichen sclerosis, but what other conditions could be causing kind of the symptoms that you're hearing about and the signs that you're kind of seeing when you're seeing the genitals, right? And having a proper diagnosis is so, so important, because a misdiagnosis can potentially make your symptoms worse. Or at best, they do nothing to help. And that's at best, right? So that's not really the most ideal of circumstances. But it really is unfortunate because there's such a lack of information for penile lichen sclerosis, and there's such a lack of support spaces for people with penile lichen sclerosis. And I feel this heavily. One of the reasons that I do so much emphasis on vulvar lichen sclerosis is I often speak from a lived experience and share my story and my journey. So obviously, well, not obviously, but I am a person with a vulva. So when talking about this, I'm not going to talk about, my penis. I'm going to talk about my vulva and what that means for me and my experience. There's also substantially more research on vulvar lichen sclerosis compared to penile lichen sclerosis. So my access to that is quite easy for the most part. Digging up information on, penile lichen sclerosis is a challenge. Finding specialists, experts in this field who are willing to come on my YouTube channel and speak about penile lichen sclerosis is one of the biggest challenges. I've been emailing different practitioners at hospitals and universities ever since the beginning of 2024. And I don't know when this is going to go up, but I started emailing in January, and it is now almost August, and they don't even reply to me. A couple just said, no, not interested. No, I'm not really that much of an expert, or I don't actually know that much. I do urology, but I don't really know. And so, there's such this lack, but you and I both know that there's a need, because even though I do vulvar lichen sclerosis, my email is often full of, I have a penis and I think I have lichen sclerosis. Where can I go for support? And I always feel sad when I say, well, there's not really much out there in terms of support. I think there's maybe one group that's on Facebook solely dedicated, called Lichen Sclerosis for Men or something, but it's very small. There's not a lot of people in there. And from what I can see from the outside, it's not very active. Reddit is actually probably the best space to go to if you have a penis. It really is mixed in there, and people of all genders kind of post and ask questions. And I think from what I've seen, that might be one of the best spaces to get support and connect. But in terms of are there nonprofit organizations? Are there big Facebook groups? Are there big virtual meetups, in-person meetups? You just don't see it. And it's a shame because, again, I know there's a need, but no one wants to do that. And as someone that is a patient advocate and that does have so many platforms, it's a lot of work. It's a lot of work. And I think, just a lot of people either, don't have the time to do that work, or again, it's putting yourself out there in a very vulnerable way. I always joke that if you've Googled me in any capacity, you probably know what my vulva looks like, because I've described it in such meticulous detail at this point that if you just close your eyes and you took an educated guess, you're probably right at this point. I talk about my sexual health, my struggles. I'm so there's nothing about my body. I talk about my anal fissures, my constipation, that's all out there, right? So, that's not exactly an exciting thing for everybody to want to just dive into and do. So yeah, it's a challenge, but again, it's so needed. It really is.
Yeah. Thanks for doing this. Thanks for doing it. Thanks for talking so openly about all of those things that are so challenging for so many people, particularly
100%.
like everybody. And we were talking about people with penises. And one thing I've noticed on men's groups in Reddit, just looking at health stuff, is that even for something like, it could be lichen sclerosus, but it could be a fungal infection. You don't need to go to a doctor. Just get this from the pharmacy. Tell them it's for your girlfriend. Or men that know doctors. I've known men that know doctors that say, hey, I think I've got this thing. Can you give me a prescription? Right? It's this real... there's not much for people with penises in terms of this kind of support. So it's kind of chicken egg, like
I was gonna say.
But the thing is, if people start going and kicking up a fuss, then there'll be more.
I was gonna say it's almost this vicious cycle, because I think that penile lichen sclerosis is grossly underdiagnosed.
Yeah, me too.
I think cases go seriously under the radar. And part of that is due to the barriers that we discussed.
Yeah.
If people aren't getting into the office, they certainly won't get a diagnosis.
Yeah.
If no one's getting diagnosed, doctors are going to think it's super, ultra, uber rare, or like isn't really a thing. So it's not on their radar. So when they're doing, if they actually do an exam of a penis, they're not even thinking about lichen sclerosis. And so when all these things come together, what you can get is a lot of missed cases.
And it's not just about examining the penis, it's the scrotum, it's the skin around, and it's particularly the external anus as well. That's where it can be most obvious, particularly if the person has been circumcised.
Yeah, and that's another interesting one, because that's another one that I really struggle with to find evidence-based information. Even in the lichen sclerosis, the vulvar lichen sclerosis realm, at most you'll have them talk about the classic figure 8, which is where the lichen sclerosis affects around the vulva and around the perianal skin back up. So they talk about that figure of 8. That means there's both that kind of like
I thought the figure of 8 meant the whole around the anus.
I thought it meant around the vulva at first. No. I thought it just meant like the whole vulva, like around the clitoris, around the vaginal opening and back up. That was my figure of 8. Your figure of 8 was around the anal skin. No,
because that's how I see it on people. I see it all around the anal skin and going up the skin between the anus and the coccyx and just beyond will often be very white and taut and very easy to rip in ways too.
Yeah. Yes.
Right.
Yeah. So, they'll be like, it affects the figure of 8. In pediatric patients, constipation tends to be a big symptom that's reported. So, constipation might be mentioned, but they don't really talk about it in vulvar lichen sclerosis research. And then I've tried, on PubMed and Google Scholar to plug in like anal lichen sclerosis, perianal lichen sclerosis, like every synonym that I can think of to capture what I'm looking for. And it's really hard. Again, trying to get an expert speaker to talk specifically about the perianal skin and treatment there and how it presents and any kind of differences that may be important to highlight. And so it's a huge challenge. And again, that's something that affects people of all genders.
Yes.
That's just like across the board. We all have an anus, we all poop. Not everybody poops out of their anus, but still.
I see this on my body. I see it on my clients' bodies. If it's when I say genitals, I mean the whole area. Like I mean anus, genitals, everything. But I will see it vulva, penis, and anus. Like I've never not seen it on the anus as well.
Yeah, right. And that's the other thing too, is that I also think that a lot of people don't get it properly diagnosed or told that they have it in the anal area. And I think the big issue there is that at least if you have a vulva, a lot of us are going to gynecologists who really kind of stop at the perineum at most, right? So it's like, okay, we got the vulva and stop. They don't examine the perianal skin. And that puts us as patients in this really bizarre position where we basically have to beg them, like, can you please look at my anus? And what kind of patient wants to beg a doctor? We're already
can you look at my butt? Please look at my butt.
And we're like hanging off their table in stirrups with our pants down in this teeny tiny little sheet that like, what's the purpose? Who knows? Because like anything else you're seeing is like easy peasy. And you know, I'm scared, I'm vulnerable, and I don't want to have to beg you to look at that area. But most people, and this is pure anecdote, by the way, there's no like statistics on this. This is purely my experience as like a patient leader who's spoken to hundreds of lichen sclerosis patients. They don't do it for the most part. Even dermatologists sometimes don't do it either.
Nope, I have to force mine. It's like, can you just look at my anus?
Like, I'm still convinced that I have it there too, but I'm hesitant to put an ultra potent topical corticosteroid on an area that hasn't been properly diagnosed, especially because I know that perianal skin is different than the vulvar skin, and often it has a hard time with clobetasol and the ultra potent steroids. So often it's a different steroid used for the perianal skin. Often, usually a mid potency, something like triamcinolone is recommended. Sometimes an antifungal is even compounded with a triamcinolone for that area. So I'm kind of hesitant to put it on there, but I'm pretty darn convinced I have it there. But getting somebody to look is so hard. And if they look, they often don't know what they're looking for, is the other thing. So even if you do get them to look, they might say like, yeah, that looks normal. And you're like, okay, well.
And this is the crazy thing about talking about this, because here we are saying it's underdiagnosed. Not many people know about it. And it feels a little almost insane to be talking about it and saying you get so many people talking to you about it. I see clients with it. Like, I don't see hundreds of people. I don't see that many people. So it feels like, just kind of like, it feels strange to be speaking up about this. I'm doing it because I believe that it's important. I have it myself. I think I had it since I was a little girl. I was diagnosed last year. I think it's been unsubtle for like 25 years. And nobody saw it. My doctor, who sees my genitals a couple of times a year, never saw it. I knew what lichen sclerosus was, because I had learned about it. I didn't think I had it, but I saw scar tissue on my vulva, and I could only see it because I see so many other vulvas. And I went to my doctor and said, hey, I don't know what this is. It's not lichen sclerosis, is it? And as soon as I said the words, she said, let's have a look. It took 30 seconds, and she said, you can put your pants on. I'm kind of like, do you want me to show you where the scar tissue is? And she said, it seems really clear. So I wasn't diagnosed. I've been going to for years for doctors about this, that, do I have an infection? What's going on? And I had to take care of myself.
And you're definitely not the first person that I hear this from. You know, so many of us, I think it's always funny, you know, when doctors are like, get off Google, like, and all of this. And it's like, well, the reason I'm on Google is because nobody can help me, because access to healthcare is so challenging. Or if I'm able to access it, I keep getting told that it's all in my head, but I know there's something off. And I saw on Google that, you know, there are these like white patches and resorption, and, you know, the symptoms fit. And could it be lichen sclerosis? And they go, oh, well, yeah, that's it. That's what you have. And it's just like, well.
Well, mine was so obvious that it was seen within 30 seconds.
I mean, me too. When my GP finally diagnosed me, it was like I said, she like walked in the room and she's just like, Jaclyn, you have lichen sclerosis. And I was like, okay, what's that? And then she did proceed to do like a more detailed clinical examination where she basically explained everything that she was seeing, like the clitoral phimosis, the labial agglutination, the scar tissue, the loss of pigment, the texture changes. She basically explained all of that, what she was seeing, which was helpful because at that point, I hadn't actually examined myself or ever looked at myself. I had no idea. One thing that really caught me off guard or stuck with me is that during this exam, she said, have you always looked like this? Has your vulva always looked like this? And I sat there and I said, well, I'm 31 years old and I can't answer this question because at 31 years old, I've never once looked at myself because, again, it's not really something that we're encouraged to do. You know, sex ed certainly never taught me to examine my genitals. It just told me, like, don't have sex STIs are bad, don't have sex. So that wasn't really productive.
So no matter who you are, even without lichen sclerosis, and hopefully you won't have it, if you've never looked at your genitals in a mirror, just start. They're so beautiful. Right?
Yeah.
So important. It's such an important relationship.
And I wish that's something I was encouraged to do earlier, but it's okay. Better late than never.
Even with lichen sclerosis, they're my genitals. I think they're beautiful in their own way.
Yeah, I think mine are too. Yeah. I'm always like, look, she's so small and petite and cute. I love her like this. Like, it's okay now. I love her. It took me some time to get there. That I'm not saying that like the first time I looked in the mirror is actually the complete opposite. And I remember using words, like very profound words like disgust and unworthy and gross and ugly and unlovable. And it took me time to kind of heal and move through that. But now I'm like, oh no, she's super cute. I love her. Like, it's fine.
Yeah. And so the other things we're going to talk about are, and these things are good to know for a lot of other people that don't have lichen sclerosis as well. The things we're going to talk about clitoral phimosis. We're going to talk about the role of hormones. We're going to talk about adjunct therapies here, or adjunct things to do, not necessarily therapies. So hormones, touch, even vibrators. So hormones is a big topic.
It is a big topic. It's a very complex topic. And it's a topic that a lot of healthcare providers are afraid of, to be honest. So that's, when we talk about barriers to the conversation that we're about to have about hormones and the role that they potentially play with lichen sclerosis, it's not easy to approach your doctor about hormones, especially if you are kind of pre-menopausal. There's a lot of hesitancy around even discussing hormones in younger folks. So, there's definitely some issues there that, need to be worked through and massaged through. But Rachel, you used the term adjunct, and I love that term. So I did give an overview of what LS is, but I didn't really talk about treatment. But the main kind of gold standard treatment is ultra-potent topical corticosteroids. So the big name that a lot of people are going to know in North America is clobetasol, but there are many different types of steroids in varying potency levels that can be used. So don't think that you only need to be on clobetasol. And if you want to learn more about treatment, I do have a free ebook that kind of reviews every single treatment option, things in the pipeline, adjuncts, and all that. I really want to just kind of dive into the hormone piece because that's something that gets less discussion right now. But there is, for folks that are interested and do want to learn more about the treatment piece, I have tons of free resources on that.
And so, the difficulty with the treatment piece is that it's generally, it can be different things, but there's generally one main thing. You're generally told to use it once or twice a week, like there's different protocols, and then it's for the rest of your life. It doesn't actually take away any damage that might be done generally. So it's basically there as a preventative for further damage, which isn't the case for everybody. Like, it doesn't work for everybody. And it's also there as a preventative, hopefully, for the other thing that can happen and isn't surprising with all the changes going on for anything like cancerous or precancerous. So it's there as a preventative. So it's not really a treatment.
It's not a cure, essentially. So lichen sclerosis is progressive, which means that if it's left untreated, signs and symptoms can worsen over time. That can progress very fast in some folks. That can progress very slowly in others. LS is really, truly such an individualized condition, but it is chronic and it is progressive. And that's the reason that steroids are given as a long-term. It's usually, some doctors will do a per need basis, but most LS specialists that I know will kind of follow evidence-based literature and prescribe, maintenance ongoing for life until we find, maybe a better option. And what those steroids are doing is they're reducing inflammation. which is important because LS is one of the most inflammatory skin conditions out there. It causes it's highly inflammatory.
Oh, it's so sad.
It causes an overactive immune response, and that's what leads to that high level of inflammation. So you want the inflammation to go down, and you want to calm the overactive, immune response. And the steroids does both of that. It can help, reduce the amount of flares in the future. It can help stabilize and manage symptoms. There are a couple of studies that kind of support its role in preventing vulvar cancer to progress. So it has its place there. Unfortunately, one thing, steroids, they're really good at doing their job in terms of reducing that inflammation. And that's been proven time and time again in really well done randomized control studies. But one thing it cannot do is it cannot really reverse anything that's already happened in terms of like fusing, right? So like and by the way, like I'm in remission. I haven't had symptoms in over 4 years. And I'm very well managed. Like people, like clinicians see my vulva and they go, I would never know that you had lichen sclerosis. If I didn't read your file, I would just assume you were born with, no labia and call it a day because everything looks so good and so healthy. And despite that, though, I still use my steroid. Yeah. But what it can't do, it doesn't give me my labia minora back, right? Like those have been lost, those have been resorbed. So steroids can't kind of like rebuild tissue or give you back lost things or parts of you. So, and they are looking at fat grafting in the UK to potentially boost up and volumize some of these parts. There are different, types of regenerative medicine being explored for these areas. But steroids are not going to be the ones that do that. And so an adjunct to the main, treatment, i.e. steroids, are things that you're adding on. These things are not reducing inflammation or calming that overactive immune response, which is what researchers, scientists, and clinicians require for it to be classed as a treatment. Yeah. It's an add-on. So, I always think about it as like stacking the cards in my favor. What else can I do? Because, and I use steroids. I think they're, very good at what they're doing. So I'm definitely not the like anti-steroid person. That said, I always tell people you can throw all the steroid you want at your genitals. But if you're not taking a broader picture and looking at your stress levels and your lifestyle and all of these other things that play together in overall health and well-being, you may never get to where you want to be, which for most, for us, like the goal is to get in remission, for the skin to look as healthy as possible, for us to feel as symptom-free as possible, for us to go on just, living our lives and having a great quality of life. But steroids are just one piece. So, there's always little parts that we can borrow from other areas to kind of amplify the effects and make it more likely that we're going to get into remission and get there faster. One of those is, hormones. One big one that gets talked about a lot, estrogen, estradiol. To be clear, this is topical. So they're talking about using topical estrogen, something that's like a cream ointment being applied to the skin. So it's not like, a pill that you're taking that has systemic effects. Just like your steroid, it's a cream or an ointment being absorbed locally, not affecting you systemically. And that's applied. Everybody's kind of different, and it may depend on your age and a bunch of things. Some people do vaginal estrogen as well as estrogen to the vulva. Some people will just do estrogen to the vulva. And then a lot of specialists are also now compounding estrogen with testosterone and applying that to the vestibule, which is very it's like a very hormone happy area of the body. It's really like receptive to hormones. So a lot of people are getting a kind of estrogen testosterone combo. At bare minimum, an estrogen piece is in there. Just full disclosure, I'm 37, and I use both vaginal and vulvar estrogen as an adjunct to my lichen sclerosis. I was a little bit apprehensive about asking because of my age. I know I'm not really in that menopausal category. And when young folks with lichen sclerosis ask for hormones, we're often met with you're too young. And again, it's, try to explain that, like 1 year's worth of topical of vaginal estrogen is equivalent to one HRT pill. to put things into perspective. The testosterone that we're being prescribed is below the therapeutic threshold. It's a low dose. It's not going to have the kind of side effects that people are afraid of. And it can be a wonderful adjunct to your treatment plan because it does a lot to kind of make that vulvar tissue nice and healthy, elastic and lubricated, and it can have this slight plumping effect. I will tell you that it was such a game changer. And for me, like, I was already in remission and symptom free. When I added estrogen in, it was like a whole nother level of like, wow, I didn't know my body could feel this good again. And for folks that know me and follow, right? I was like, why did I wait so long to ask for this? And truthfully, I think it's because I thought I was going to have to fight so hard and I didn't have the energy to fight for it.
A lot of people have to fight for that.
Exactly. And I think the challenge too is that there's not a lot of research on hormones and lichen sclerosis that's been published. And so when you're asking for something that you can't just pull like 20 papers on, it can be a bit challenging. And it's a little bit harder to say, well, all of these experts have, found benefit and prescribe it to their patients. It's a little bit harder. I will still give my doctor, the book When Sex Hurts. Look, these are some of the most renowned specialists in the world that will prescribe a compound of testosterone and estrogen to the vestibule. Dr. Rachel Rubin. There's an episode on Lichen Sclerosis Support Network's YouTube channel, which I also create content for them. I did a podcast or a YouTube video with Dr. Rachel Rubin, who is a urologist, sexual health medicine for all genders. And she pushed the estrogen big. Go and watch that if you're curious. And she's also way better at, really explaining, estrogen and all that. Definitely go check it out. It's a great conversation. But more and more and more people with lichen sclerosis are being offered estrogen and or testosterone and estrogen into the mix. And I even used testosterone for 8 weeks off label to help with phimosis. So again, just like another potential area for hormones to come in as a kind of adjunct, as something that can just, improve our quality of life a little bit more.
And there's even so I'm postmenopausal. I got the estrogen cream, but I'm also taking systemic estrogen and progesterone. But my doctor's very keen on taking away the estrogen cream from me, even though I have lichen sclerosis and even though it's beneficial. So I'm probably going to have to fight for that, even though I'm postmenopausal, and it's a no-brainer.
It's wild. It is. It's such a no-brainer.
Our genitals don't matter. Our pleasure doesn't matter. The last time I went to a sexual health clinic, I had a young nurse, and I was saying, well, I use this because I'm feeling a bit of dryness, and now I don't. And she looked at me and she said, what did you expect? And I thought, what? I thought, no, I expected to have good sex until I was 100. Human in front of me. No, if I have access, if hormones are really going to support me in this and help my genitals feel good, as well as all the other benefits that it has for urinary stuff, for just everything and comfort.
That's what I was going to say too, right? So when you take a systemic pill, estrogen, something like that, that's working on the kind of vasomotor symptoms, sleep, mood, brain fog.
Because the brain is hungry for estrogen. So it goes there first. And then all the bones, all the estrogen receptors in all the ligaments, right? Genitals come last.
And then so the vaginal estrogen is for the genitourinary tract. So people going through menopause may experience something called GSM, which is genitourinary syndrome of menopause. And these are things that, instead of the symptoms being cognitive or motor, it's symptoms that are affecting the genitourinary tract. So that can be the vagina, the bladder, the urethra, the vulva, all of those things. A common thing is chronic and recurrent UTIs. And one thing that Rachel Rubin is adamant about is give people through this transition, they need to be on vaginal estrogen. These chronic and recurrent UTIs, which by the way, can kill people. Have the most simplest solution, and it's vaginal estrogen. So,
easy.
the fact that you may have to fight to keep that in, both as someone who's postmenopausal and as someone that has lichen sclerosis, this should not be the case.
It's
And I hope that in 5 years, the landscape is going to change, because it's absolutely absurd that someone in this position potentially has to worry about fighting to advocate to get vaginal estrogen.
Folks that have given birth and are breastfeeding, drop in estrogen, often get symptoms of lichen sclerosis for the first time. It's a no-brainer to give them the estrogen as well, topically.
Yeah. And another interesting conversation that I have on the topic of hormones would be a video I did with Dr. Corey Babb on, is there a connection between hormones and lichen sclerosis? Why does some people feel more symptoms when they ovulate or before they menstruate? Why do some people feel better when they menstruate? And all of these things. And the world of hormones is so diverse and so complex. But there's a lot there. Older lichen sclerosis research used to cite this like bimodal peak, which is like 2 peak incidences where lichen sclerosis occurs, and that's in prepubescent kids and postmenopausal people. And what do these 2 age groups have in common is low estrogen states. Low estrogen states is associated with itch, which is a common symptom that people will report. That's not to say that you have to be in a low estrogenic state to have lichen sclerosis, but there does seem to be some kind of connection there. And then, there's just, again, it's all incredibly complex, but I think the more that we talk about it, the more research is done, the more patient advocates as well as different stakeholders in the medical field really advocate and encourage these conversations to keep going. I think there will be some change. I was so shocked when I went to my family doctor and asked, and she, without skipping a beat, said, "Yeah, what do you want?"
Amazing.
Which of the options would you like? And I was like, it took me a minute because I was so ready to fight. I was so ready to be like, here's what I want it, and da 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 da. And she's just like, yeah, okay, sure. I was like, oh, okay.
So even without lichen sclerosis, for genital health, like hormones can be very supportive. I don't know the role of testosterone in all genitals and how that can be helpful, but if estrogen is so helpful, then there must be more going on that I don't know about, and testosterone must be a part of that landscape.
100%. And it's something that needs more research, both in lichen sclerosis context and in non-lichen sclerosis context. We just don't know enough. We just don't. And
general long, good health of our genitals for all of our life, I think. And a lot of other things. Hormones play a huge role, and there's just not enough good, solid. I mean, people are doing research on it now, and people are talking about it, but it hasn't hit the landscape of going to the doctor and getting that kind of support, or saying, "Hey, do you want to try this? Do you want to read this and decide what you want to do?" Because it is complex and it is a decision.
Very, very complex. Yes.
So that's something general. That's something that can be supportive for folks with lichen sclerosis or not, depending. And the other thing, the 2 other things, gosh, this is a long talk.
We kind of knew that coming in, though, didn't we?
Yeah, we
lichen
did.
Sclerosis is such a big topic. I mean, I actually met Rachel at in Montreal, and I was like, oh, I'm going to talk about lichen sclerosis. We'll have 2 hours. That'll be more than enough. No, it's never enough.
Yeah. And then there's so much that we're not talking about today as well. Okay, so phimosis, clitoral phimosis, you did a fabulous video on that. Maybe I'll even put a link to it in the show notes.
Yeah, I think we'll link to it because I have, which I do not have with me right now, but I do have a vulva puppet. I really like using props for education purposes. All of the parts move, which I find is really helpful for really illustrating what's going on in our bodies. So we'll definitely link off to that for anybody interested, for sure.
That's really good. And also, so I had a clitoral phimosis, you had a clitoral phimosis, and I noticed when I just started learning about lichen sclerosis, I noticed a lot of folks have clitoral phimoses, and some of them discover it just by themselves, just by touching themselves more, that they can reopen it again.
Yeah. Mm-hmm.
So the phimosis are different. Like some take longer, some are faster.
Yeah.
But yeah.
Mm-hmm. Yeah. And what's interesting about phimosis in the context of a clitoris is that this can happen in people without lichen sclerosis. Yep. So that's another thing. If you are listening and you do, you listen to this whole podcast and you go, gee, I'm going to look at my vulva for the first time. And you go, I tried to pull back the hood and I tried to retract and it wouldn't retract. There was no motion to expose the glands. Oh shit, I must have lichen sclerosis. Not necessarily. No. You could, but you also could not. Clitoral phimosis. So it's kind of like clitoral adhesions is when the glands will kind of stick to, scar to. The hood will stick to or scar to the glands, and that comes in degrees. So Dr. Rachel Rubin has a great blog post for people that are okay to look at real live vulvas. And what I love about this post, I'm such a visual person, and having actual images of vulvas illustrating the different stages of, clitoral adhesions and to like full on phimosis is really helpful. So the first is no phimosis, no adhesions. The second is mild, moderate, severe. So you can kind of see the different stages and what they look like, because not everybody is like fully phimosed where like you just can't see the glands or anything. You can barely retract. How it presents on different bodies can vary quite significantly. Now, for me, it was like full. Like I was number 4.
Me too.
I was
on the
severe.
Picture. I was the full as well.
Yes, yeah, that was me. And if I tried to retract, not only could I not expose the gland, but the tissue, like the hood, barely moved. Yep. Like it was so thick and rigid and stiff, which, again, think about the word sclerosis means hard, stiff, rigid. So, again, makes sense. There's a lot of scarring in that area for me. So I could barely get any mobility or like moving of that skin. And again, so this can, and that blog includes people with and without lichen sclerosis. And this blog is actually like a blog form of the study that they did. So for like uber nerds like me, you can also link off to the actual study if you want to read that. But the blog post is a kind of more digestible form. And that's where she has that really nice picture again for folks that don't mind seeing that. But yeah, mine was fully phimosed. And I think, for me, what I really want people with, lichen sclerosis or, even just phimosis for another reason to know is that there are ways to unfuse this. There are ways to get that tissue moving again, to get it so that you can expose it. So it's interesting because both Rachel and I were fully phimosed and then completely unfused in different ways. And there's other ways that exist that neither Rachel or I did either, right? So like there's surgical procedures called a lysis of adhesions, which is quite common in the United States. It's a procedure that they can do to surgically separate the hood from the glands. There's, Rachel Rubin has a slightly different technique done in office to unfuse, which really focuses on like stretching and retracting that hood in office. Now you're completely numbed up because she's going to go a little bit more intense than say what I did at home. And then there's these kind of like non-surgical things like clitoral myofascial release, which is just a kind of way of like massaging and moving the tissue to slowly and very gently over time break up some of that scar tissue, bring blood flow to the area, and help that tissue become more mobile and able to move again. And slowly in time, you'll see that you're able to retract a little bit more. So touch and different types of, touch techniques can work. Yeah. That was a part of what I did. So I did clitoral myofascial release. I also did sustained stretching where say,
me too. Yeah.
Yeah. So I would take kind of, the index. This is the index finger, right? I don't know.
Yeah.
Well, whatever finger this is.
This is the index.
Okay. I don't usually have to name my fingers. So I'm like,
you got it.
I'm not too sure about this one. So, I would kind of take the index finger right at the base, right where the hood would end. And I would try to retract. Now, in the beginning, I wouldn't get much motion, but I would retract and pull it back until I felt resistance or discomfort. One thing for me was that I never wanted to move into pain because I didn't want to teach my brain. I didn't want it to make kind of new neural connections where I've created this like touching clitoris equals pain equals danger. I didn't want any of that. I wanted it to be really gentle. So I would pull it back until I felt some resistance or mild discomfort. And then I would just kind of hold it for a minute or so, let it go, chill, do it again. And I kind of built my tolerance up. So towards the end, I would retract for like 5 minutes and I would be so bored. I would like play on my phone. I would like you're just holding it.
I'd play really good music or watch a really good video.
Yeah,
but also
like
did
you
this.
got to do something.
So the clitoris, which is not my nose, but my nose, there was a long white line covering. Right.
Yeah.
So I would also like gently just stretch it. Right.
Right. Yeah.
So I would do that.
I mean, all of these different techniques.
And also move the skin around because it really stopped moving. And gradually, like, I noticed when I would do it, like, suddenly something would move that hadn't moved. And then once the skin started opening, when things moved, it was like gritty pieces of dark sand would come out. And a lot of people talk about that. So
I mean, I can't say what that was, but for me, especially as I was unfusing, I used to get a lot of keratin pearls, which is essentially a buildup of smegma.
Yep.
Now, smegma sounds really, it's not the greatest of words, and doesn't sound very nice. It's basically
I like the
grains and like
grains of sand were better.
yeah. But and all bodies produce this, by the way. But normally, when you wash in the shower, the smegma buildup leaves as you clean yourself. But if you're fully phimosed, that smegma balls up under the clitoral hood and has no way of getting cleaned out. So it balls up, and like Rachel just said, it forms into this really hard ball, and it kind of feels like, Dr. Krapp will say, feels like a grain of sand stuck in your eye, but obviously like so much worse because the clitoris has so many nerve endings, and people with lichen sclerosis are also, we already got that pain and everything's going on. So it's great. So when I started to unfuse and I would like retract, sometimes I could see we call them keratin pearls, and I could just kind of get them out on my own, which was nice. So, there could have been some of that, but there's a lot of things actually when doctors, and we're really trying to push clinicians to examine the clitoris.
Yes.
Because that we talk about vulvar exams, but vulvar exams often don't include or involve the clinician touching or looking at the clitoris. And that's a big, big, big problem because adhesions go missed. All these things can get missed. But for the good ones that are moving and looking and examining the clitoris, especially with lichen sclerosis patients where there's often some degree of scar tissue and scarring and sticking together, they remove pubic hairs that are trapped.
Yes.
They remove dead skin cells and debris that gets caught under. There's a lot of things that can get trapped under there. And it seems so small, but again, our clitoris is so dense with nerves. So you feel that. You really, really do. So a lot can kind of show up and come out. And I hear doctors all the time, telling me, oh yeah, like you can pull like 20 pubic hairs that get caught up in there. Again, just, I haven't really had that issue since I unfused, but I was doing a lot of similar techniques to you, sustained stretching, myofascial release. And I did also include topical testosterone. This was given to me kind of off label. And it was really kind of beautiful that it was given to me at all, or even offered to me. So basically,
I tried by the time
I saw, it's hard, right? Yeah.
Yep.
It's really, really hard. So essentially, I saw I saw a vulvar specialist. Now, it did take me 3 years to get in. Now, we are both in Canada, so Canadian listeners know the long wait times we can have sometimes, but some listeners from outside might be a little bit shocked. But yes, it took me 3 years to get in. Now, by that time, I was in full remission, no symptoms, didn't really have any issues other than the fully phimosed clitoris. And I just looked at her and I said, hey, you know what? I know we don't really do the surgery much in Canada, and that's okay. I'm not looking for surgery, but like, what are my options? What can we potentially do to help me with this? I said, I just found a pelvic floor PT who's going to show me clitoral myofascial release. I'm going to incorporate that with some sustained stretches. But is there anything else? And at this time, I didn't even think of testosterone. I didn't even know it. And she said, Well, there's one doctor that I used to train with, and he's now since retired. So if anyone wants to know his name, he's retired, unfortunately. But she says he's at Sunnybrook Hospital, and he uses a laser to separate the glands from the hood. But she said before he does the laser procedure, he puts every single person on 8 weeks of topical testosterone daily. And here's why. I'm going to make like a hot dog with my hand for anyone who's watching the video version of this. So what's going to appear to be the hot dog, that's the clitoral glands. My hand wrapped around it very, very tightly is the hood that's very rigidly stuck. So I'm trying to pull it out and nothing's moving because this is so scarred and wrapped around it. Now, what the testosterone does is, again, I'm taking this below the therapeutic dose. So it's not going to have extreme effects, but it will slightly increase the size of the clitoral glands. Yeah. And as that gland slightly grows, it can kind of break through some of those adhesions. Now, for him, his perspective is that just gives him better margins to go in with the laser. So that's why he does it. And she said, well, you know what? Like, he does this. I'm happy to refer you to him if you want that procedure. She said, but I'm also happy to just start you off with 8 weeks of testosterone, because either if you go there or not, he's going to want you to do that. So she said, I can start you on this. Now, this is what a good clinician does. They explain to you that there's no research supporting this, which just means we don't know if it's going to work. We don't know how you're going to react. We can't predict this. So it's kind of, a bit of an experiment. No guarantees. She explained potential side effects, which were acne. I said, yeah, no problem. I'd rather a functioning clitoris. I can deal with some pimples. I'll put on a pimple patch. Problem solved.
I'd take the clitoris any day.
yeah. Bring on the acne. It's fine. I'll manage. I said, and then she goes, next she goes, hair growth. And I said, okay, do you mean like hair on my head? Like I'll suddenly have hair down to the middle of my back like I always wanted, but can never accomplish because I play with my hair too much? Or do you mean like hair on my face? Like, what are we talking? And she said the hair growth when you're taking topical testosterone is typically restricted at this dose, restricted to the pubic area. Again, I said, no problem.
Yeah, no
That's
problem.
fine. You can give me the biggest bush in the world if I have a functioning clitoris. That's okay. If I don't like it, I can remove it. No problem. She goes, well, the next side effect, is actually kind of a happy side effect. A lot of people really like this one. And that's that your libido can increase a bit. By the way, it does. And it is indeed a happy side effect. Love it. So those were, kind of what she said. And then she said, the glans clitoris can grow a bit. Not so substantially at that dose, not so substantially that it, gets, large enough, but, just letting you know in case that's an issue for you. Again, I said, yep, no problem.
No problem.
Hand
more
it over.
Clitoris, more pleasure.
Right. I was like, yep, that's totally cool with me. So she gave that to me. So I did this kind of combination of, I would take a shower in the morning and then I would do the clitoral myofascial release, different movement techniques. I would then do the sustained stretches, building up my tolerance. And then I would really rub on that testosterone. It was 2% testosterone compounded into plain petroleum jelly. I would apply that to the clitoris after all of this. And I did this every morning. By 6 weeks, it was completely unfused for me, like completely unfused by the time I went back in her office. And she's one of the hospitals that does take pictures. So what was so cool was she had the FIMOST Jaclyn on her screen. And when she got on her little stool and got up in there to look at my clitoris, she I don't know how to say, like flung herself back on her chair and was like, oh my God. She goes, you completely restored your anatomy. Like you're completely unfused. And she was in shock. And then, she took the picture and then we did a side-by-side comparison. It didn't even look like the same vulva. It was ridiculous. It was so cool to see. And some people ask, like, is testosterone necessary? And I say, I don't know. Because in my instance, it's kind of hard, right? I kind of muddied the data in a sense because I was doing clitoral myofascial release. I was doing the sustained stretches. I was doing testosterone. So it's kind of hard to say, like, who did the heavy lifting. But what I love about your case is that there was no testosterone involved. No. So what this tells people, and so even if your provider is not willing to give testosterone, it's not the be all end all of unfusing. There are other ways that people have accomplished this without, topical testosterone. Of course, if your provider is willing to give this, then great, but don't feel, if like Rachel asked and they were like, no. So if you also get a no, know that maybe for your journey is going to look more like the gentle, touch and different touch techniques and movement techniques and bringing blood flow to the area. And for some people, this, blood flow, if it's okay with you, Rachel, kind of pivot us into vibrators, because that's another potential, not necessarily way to like unfuse. Like, I'm not saying like, again, take a magic wand and just jam it onto your clitoris and bam, you're unfused. But again, it sounds, like we said that before. And I'm like, please don't do that. Never start there. But,
unless you know way because it's good.
Exactly. Unless you know what the magic wand is, you can tolerate it, your speed, all of that. Good. But if you're kind of new to it, do not start with that and do not jam it onto your clitoris. Don't do it.
But first, before we go to the vibrators, I wanted to say one thing about like the clitoral hood and the foreskin as I don't believe that they serve very different functions. And I was listening to somebody, I've listened to Gil Hedley talk about the foreskin, and I listened to somebody else, and it seems like the intact foreskin on a penis, it actually helps the build to pleasure. It helps the build to orgasm. So it's smooth, sustained, and it actually builds into something that feels really good. And you can feel it as it goes, and you can be with that. And I noticed that when I was working around my clitoral hood and all the adhesions, there was no movement of the skin around the glands. So I think of it the same as a penis, and it changed. My orgasms had changed completely over a period of about 5 or 8 years, like slowly. And I was thinking, what is going on?
Right.
And once that could move, some of what I used to have came back in terms of sustainability and build and easeful orgasms of the clitoral glands, of the clitoral creature that it is. The whole thing. So,
and truthfully, penises and vulvas, they're so similar, like the clitoris and the penis, so similar. Actually, that blog by Dr. Rachel Rubin up at the top, I believe, even before you get to the pictures, talks about the overlap and similarities about, the penis and the clitoris and how they're essentially the same thing.
Yes.
Yeah. So, it's pretty wild. Again, definitely a blog worth reading if you're curious.
Yeah. I've got to find that and put it in the show notes.
Oh, yeah, for sure.
Yeah. And so vibrators, one thing I've noticed with myself, I've noticed with other people, is that there'll often be, I have angiokeratomas. They're red spots on the skin of the external.
Yeah.
And I've noticed a lot of other people that have lichen sclerosus have that. And dermatologists don't have much to say about them. There's a few things that it might be if you've got a lot, but it's kind of like, oh, it's aging. Like I've had things that I'm 25. When I was 25, a dermatologist said, oh, what you've got is nothing, it's aging. And I'm like, I'm 25.
At 25.
Yep. So angiokeratomas can be a sign of reduced vascularity in the area.
Yes.
So reduced blood flow. So anything that brings blood flow, even if you don't have lichen sclerosus, bringing blood flow into the genitals, like just gently squeezing the external labia above, like that's another thing that I do regularly is to bring blood flow, because all of that inflammation that's happening, the whitening of the skin, it's really asking for blood flow to kind of like support that and to kind of bring it back into alignment. And so I'll often do that with my hands. And then now, welcome to the world of vibrators.
Yeah. And I love that you say that too, because, one of the things that lichen sclerosus does is it thickens the skin. That doesn't always appear on the top, most superficial layer that we see. But if you look at biopsy samples, it's really characterized by very thick, hard, rigid skin, which means that blood flow to that area is going to be harder. And to your point about the blood vessels,
as well.
And the blood vessels are not spared from this. The blood vessels, they also show sclerosis. So kind of they're, again, thicker, harder. So we're getting a harder time getting blood flow to that area. And we know that blood flow is really helpful for tissue healing and tissue repair. So if we can do things to gently encourage blood flow to that area, it can be another one of these things that, again, is kind of like this adjunct. Like, we're treating with, our steroids, but then we're also bringing in hormones, and we're bringing in different types of touch techniques to kind of move scar tissue and bring blood flow to the area. And then again, to your point, you know, there's many ways that you can do this. And for some, starting with your hands might be the best way to go. Not everyone needs to start with a vibrator. To your point, you know, just a gentle massage of the tissue around the vulva can be. I may advise not to do this actually, and I would have maybe advised not to do this or with a vibrator if you have any like active cuts or tears or wounds, ulcers, anything like that.
Absolutely.
Just, and that doesn't mean never, that just means let that broken skin heal first. But if you've got, you know, a cut and you're massaging, it's probably just going to aggravate it, right? And then you also run the risk, even if you wash your hands, of introducing bacteria. So that's the only time I would hold off. But other than that, some gentle kind of massaging and moving of that skin can be your first line of introducing this kind of like blood flow encouragement.
I'm going to add one more piece to that. If you do have lichen sclerosis, when I was working on my vulva, I had been diagnosed, but I hadn't started using the clobetasol yet, right? And I didn't understand that there was a part of my vulva that had no sensation anymore. Or I didn't actually want to, because who wants to know that shit?
Of course not.
So I noticed I never had in the last few years any fissures or anything, but I just noticed a little red spot. So I had to wait for that to heal. Once I started using the clobetasol, it changed the texture of my skin. It only took about a month actually, so that there was more elasticity and it could tolerate movement. Like I'm very gentle. I'm a body worker. I give people genital massages. Like this is I do this. Like if you have lichen sclerosis, have a genital massage from somebody. Instead of having a head massage, have a genital massage. So, and I'm very gentle. So I did that. But once the clobetasol started kicking in, that never happened again. And I have a little bit more sensation in that area. But it made, like, the skin had no stretch left in it, and now it has enough give. So if you have lichen sclerosis or are waiting for a diagnosis, or you have active symptoms, doing this stuff, you might hurt yourself more. So it's better just to get into remission and then start gently doing this work, and gently in terms of like just not having any hurting of the self.
Yeah, I agree with that 100%. You know, focus first on healing the skin, getting it to a texture where you can tolerate gentle movement. And I too, like Rachel, I emphasize so hard the gentle nature of this. And I know that this is a challenge for a lot of people because we just want to get to the end, right? We just want to get to where the clitoris is unfused and our tissues feel good and we're able to feel amazing pleasure and there's no pain. And the tendency for a lot of us, and I've done this a couple times too, I've ignored my own, you know, advice about the gentleness, and I kind of might hold to retract harder than I should have, or gone a little bit more than I should have. And, you know, with lichen sclerosis, really it's consistency and gentle touch, right? We really don't want to injure our skin. That's not the goal here. And as much as we want to just speed up the process, sometimes going too hard to speed up the process actually sets us back. I know people who have damaged their skin by going too aggressive with stretching, and then that kind of kicked off a flare, and then they spent months trying to get out of that flare and heal the skin. And so again, it's just, you know, and the BSSVD, the British Society for the Study of Vulval Disease, they actually have in one of their handouts where they talk about gently trying to pull the labia apart if it's fused but not resorbed, to kind of unfuse them. And again, it's like, it's so gentle. It's a very slow process, right? It's not meant to happen overnight. So again, gentle is the name of the game here.
This kind of self-work, or doing it with another person, is a really deep, it's an invitation to a very deep kind of embodiment, where instead of using, any part of the body, it's a deep invitation to learning how to touch it in ways that will support the body. So listening to what the body's asking for. And this is the opposite of what most people think sexuality is. We're listening to our genitals, learning to listen to them, not to use them to have a fast orgasm, or, I mean, you can do that and reset your nervous system. This is actually, what do my genitals need? And I did a lot of that. What do my genitals need? And even before I had the diagnosis, I was doing a lot of that work. What do my genitals need? And I didn't know I had lichen sclerosus, but the things when I asked myself and I listened, and it's difficult. It's the opposite of what we think sex is.
Yes.
Then I thought, why am I doing these things? But once I had the diagnosis, it made sense. I thought, my body knew what it wanted if I listened.
Yeah. And it's a hard
process.
It's a hard thing to do if you're not used to doing that, right?
And there's a lot of grieving in the process too. Working with the genitals. If you have, even if you don't have lichen sclerosus, there's a lot of grieving with work with the genitals in accepting them for what they are. And then if you have something as well that you know has damaged the architecture of this precious part, it's this really deep process of accepting what is and grieving at the same time. And it's deep work.
It is deep work. That was a huge part of my journey. I think that probably took up the first initial 6 months of my diagnosis. Grief is something I talk about a lot on the Lost Labia Chronicles, because that was such a big part of my journey, especially as someone who, by the time I was diagnosed, had lost the majority of my anatomy. That was really a big thing for me to kind of wrap my head around. But yeah.
And how did this happen? How did I let this right?
Yeah, because for me it was very much like a self-blame thing too, right? If only I had looked at myself, I would have realized these changes. I could have advocated for myself better. I would have caught this earlier. Maybe I would still have parts that I lost, just playing those what if scenarios. And they really all centered around I was to blame for what happened. And so like a lot of that also was like letting that go too.
And that's the whole thing about genitals. They're so undercared for, under-acknowledged, so feared. It's not, one individual cannot look after their genitals. It's a whole community that looks after our genitals. And we are not there. We're not even close. But that's also why we do this and we talk about these things, is to bring all of us closer to this real acceptance and love and appreciation of our genitals, as well as safety around them and talking about them and being with them.
Yeah, 100%. It's so needed. It's so needed. So, thank you also for the work that you are doing in this space, because it's very, very needed.
Yeah, it's hard. So just before we finish, the vibrators, like, what are your thoughts on them being helpful? I think that you've talked about a study that's possibly going to be done around this too, or did you?
So there is a systematic review that looks at vibrators and vulvar pain. They don't discuss lichen sclerosus proper. It's a lot of like vulvodynia and different pelvic floor conditions. But, vulvodynia, is kind of an umbrella term, and it basically, initially is just meaning there's pain in the vulva and we're not sure why. So some people, so sometimes people get a diagnosis of vulvodynia because there's pain there, and the pain is actually caused by lichen sclerosus. So, there's that interesting piece when we talk about, when the study is looking at people with vulvodynia, it's like, I wonder if any of them have lichen sclerosus and just haven't received that diagnosis yet. But suffice it to say that kind of systematic review definitely showed a lot of promise in reducing pain in people with genital pelvic and vulvar pain. So, it wasn't specifically done in the context of lichen sclerosus, but because lichen sclerosus can have a genital pain component, then maybe there's a place for vibrators to help with lichen sclerosus from a pain perspective. There's definitely some possibility there. And I think there's some research going on there, like kind of small participants to start, but hopefully we'll see more, research in that space so that we have a better understanding of what it's doing specifically with people with lichen sclerosus. But I think for me, that systematic review is really interesting because it at least opened the door of maybe there's a space for vibrators to help people with lichen sclerosis from a pain perspective, from a reclaiming and understanding what pleasure sensations mean for you, from a blood flow perspective, right? Again, if we think about the scarring that can occur, I've had, different injuries. I lift a lot of weights, and, that just par for the course. There's injuries that come with that. And there's some injuries that I've had where, they're using different types of vibration tools, and they're like, oh yeah, there's like adhesions. We're trying to break them up, or we're trying to do this, or we're just trying to encourage blood flow to the area, right? If you go to like a chiro, RMT, physio, sports medicine type place, it's a lot of what they're doing. So, if that holds for adhesions in other areas of the body, why wouldn't it hold here? So maybe there's a role in, the unfusing process that vibrators could play. Now, obviously, I can't say that with a guarantee because there's no research on it, but I definitely think there's a possibility. I also don't think that it's a bad thing to explore pleasure and to, encourage blood flow to the area, even if the goal isn't to unfuse or it doesn't successfully unfuse. And then I think it's just a question of, how do you approach vibrators, being mindful that there's different types of vibrators, being mindful about your approach. So, for me, I always say, like, if you're new to vibrators, especially, or you haven't used them in a while since your lichen sclerosis diagnosis, try something simple, try something with multiple settings and put it on the lowest, right? Don't just start, if it has 10 settings and 10 is the max, don't just start at 10. Obviously, don't take your Hitachi magic wand and jam it on the clitoris. Like, slowly get to realize what your tolerance is, because sometimes also another thing is that while you're using the vibrator, it feels good, but then people will say, when I'm done, then I feel sore, then I feel achy, then it's burning. So that's why we want to kind of give ourselves that slow, experimental, space to kind of slowly relearn our bodies again. So again, different types of vibrators, going slowly with it. Rachel, I think we spoke about even like, you don't even need to start at the clitoris. Like, it's such a, you don't need to start there, especially if there is a lot of scarring, especially if that is an area that's notoriously felt a lot of pain. You can start with the inner thighs. You can start, along the
pubic
groin.
Bone,
you can,
and any bone nearby that you touch, like if you put it on the pubic bone, it's gonna vibrate everything around it. So it's going to be, if you put it on the pubic bone or even on the greater trochanter, the sit bone, if you even put it on the sit bone, you'll feel it in the clitoris,
right?
and a whole lot of other places. So it's kind of like, where does it want to be? And just and just taking it, just bringing it into like what feels good. I can have an orgasm, but I don't have to. And it's kind of like, can I just allow the intense energy of the vibrations instead of like, I'll often like, if I wanted to have a fast orgasm in my head, I would concentrate all the energy in my clitoris. But instead what I'll do often, I'll just, even though it might be on my clitoris, I'll expand the energy to my whole body. And that way I can use it for a really long time. I won't have an orgasm really fast with it or at all. And it'll just be like this. I just expand the intensity of it on the clitoris to my whole body, and I'll just be breathing really deeply with it.
I love that. I'm gonna play with that myself personally.
But the thing I found the most useful about vibrators is having it on the central line, not even on the clitoris, but below, because my internal labia, I do have a little bit of them back. Thank you, estrogen cream, for plumping them out for me. I will have them actually more lower around the vagina. And then if I can manage to keep it there for, it takes a long time, maybe 20 minutes. It's not everyone's thing. When I stop using it, I'll lay very still and I can feel this little thing where my labia used to be. It feels like from the inside, it's just kind of like swirling around in circles, like trying to pop back out. I don't know if it's true, but it I can feel them kind of trapped on the inside, and it's like they're like, I want to come out now.
Yeah, that is so neat. It's so neat what happens when we actually give ourselves this space to get curious, and when we slow down and don't rush things and just really be in our bodies. Such a gift. And it's something that is so foreign to so many of us, myself included, for the longest time. I mean, it's not, we're kind of taught to do the opposite. We're kind of taught to be outside of the body. So going back inward can be quite the journey as well.
Yeah. Embodiment in the body. So we feel it, because that's where the good stuff happens.
Yep. 100%.
Yeah. So that was lichen sclerosis. We just touched the surface of it.
We did. There's so many other things that we could touch on, for sure.
Yeah. Maybe we'll come back and do it again.
I would love to.
All the new research, all the new things, some of the research you're involved in. Like, it's really exciting. Yeah.
Because we're really in this kind of research boom right now. There's so much momentum with lichen sclerosis research. And when I go to these big medical conferences, 90% of the talks are on lichen sclerosis. You go to the British Society for the Study of Vulval Disease, the International Society for the Study of Vulvar Disease, where it's vulvar disease, and like 90% of it is lichen sclerosis. You go to ISHWISH, which is the International Study for Women's Sexual Health. Again, it's so lichen sclerosis. Universities are really, going hard on the LS research. So I think we're going to have a lot more to say soon.
Yeah, I hope so. Yeah. Thank you so much for your time and for coming to the podcast. I really appreciate it. Of course,
it was such a pleasure. Thank you so much, Rachel.
You can find my services for individuals and online at my website. And if you want to support this podcast, you can click on Buy Me a Coffee. Both links are in the show notes. Thank you so much for listening to episode 10 with Jaclyn Lanthier and your host, Rachel Charlie.